learn more. And this is just the schedule of today. I'm gonna do just a short presentation about our chapter. And after that, Dr. Nicole is gonna talk about N95 mask disinfection. And after that, we're gonna have a question section. And if you have some question during the presentation, you can just ask via chat. And after the presentation, I'm gonna ask to Dr. Nicole. Now, I just want to show you about our chapter. UFABC student identity is just since May 2019. It was recognized by the OSA in October 2019. It's just 1 year we have. And when we started with just a few members, but now we are with 18 members, and including professors and students from UFABC. And here is our board members. We have as president, Andre, as vice president, Gabriele, and as treasurer, Julia, and as secretary, we have Carla. And here is our members, is everyone, 18 members, a lot of pictures. It's a beautiful people. And here, our chapter is a multidisciplinary chapter. We have professionals from different areas. We have professionals from different programs, technical areas, such as physics, chemistry, biomedical engineering, nanoscience and advanced materials, science, materials engineering, biotechnology science, engineering of materials, technical areas such as laser, spectroscopy, material characterization, biophotonics, quantum optics, optical communications, nano-optics, astrophysics, Raman spectroscopy, and optical trapping. Here just a few words about Optical Society. It was founded in 1916, and the mission of Optical Society is disseminate and promote knowledge in the optics and photonics worldwide, and is non-profit professional societies, has more than 20,000 members in 100 countries, more than 5 million per year in support of education programs and extension. And here we can see chapters and sections map, how much chapters we have in the world, and is increasing and increasing, and that's amazing. We have more than 300 chapters in the world, and that's great. And here, that was a project we did, and there was an N95 mask disinfection equipment. I don't want to talk a lot about this because Nicole is expertise, she's going to talk a lot of this. But we did last month, and we did this for the UFABC Field Hospital, and we did to help fight against COVID-19, and it was a great project. And this equipment is using UV light to disinfect masks. And here we can see some pictures. And the last picture, we can see our members just training and teaching the people how to use the equipment. And it's amazing. And with this project, this equipment, we are participating in the Fleury Innovation Prize. And we are finalists, and we are happy to be a finalist. And result will be announced in a live broadcast today at 6 p.m. And now I invite you, all of you guys, to participate, to cheer for us. And if you want to watch, you can just apply to watch at this website here. And we're going to be happy if you have you with us today. Thank you. And now, if you want to know more about us, just follow us on social media. We have Instagram and Facebook. You can ask questions over there. You can learn more about optics and biophotonics there. And thank you. And now, we're going to our main event of the day. And I just want to thank you again, everyone who's watching us, to join us. And I'm sure it's going to be a great presentation. And now I'm going to present our lecturer. Just a moment. Dr. Nicole Starr is a general surgeon resident at UC San Francisco and a fellow at NIH Fogarty. In addition to performing academic global surgery, improving surgical quality, and preventing infections, she's interested in strengthening trauma care systems in research-limited settings, trauma-induced coagulopathy, and platelet function in injured patients. Dr. Starr served in the Peace Corps in Ethiopia from 2007 and 2009 to 2009 and has worked in health service research, improving care for patients with HIV, AIDS, TB, and improving surgical quality in Ethiopia, Brazil, and Liberia. Let us now welcome our speaker, Dr. Nicole Starr. Thank you for being with us today. We are glad to have you here. And I'm sure it's going to be a great presentation. It's going to be a great learn for everyone here. Thank you.
Thank you so much for the kind introduction. And thank you for the opportunity to present. Let me just pull up and share my slides with you. Okay, is this functioning properly?
Yes.
Excellent.
That's great.
So thank you so much to the OSA student chapter for the invitation. It's a great honor to be with you as a lecturer today. My name is Nicole. I'm a general surgery resident. I'm a physician from San Francisco, and I've been working in a partnership with N95 Decon, Lifebox, and OSA this year around the design and implementation of these UVC cabinets for N95 decontamination and reuse. So I'd like to present all about our collaboration together today. By way of background, I've done a lot of work, mostly in Ethiopia, around understanding why patients develop infections and preventing infections following surgery. This work spans multiple areas of the hospital, from the clinical service provision, but also to cleaning and decontamination areas. And I think really influenced our work together around shifting some of these practices towards responding to the pandemic and implementing some of these strategies for N95 decontamination. So today I want to share sort of an overview of how we've come to this point, this very exciting moment where this chapter is about to hopefully win a prize for innovation in the UVC cabinet. So I'll review some basics around COVID-19 transmission and personal protective equipment, some of the basics of N95 masks and decontamination strategies, as well as the design of the cabinet and how it was validated, and then what we've moved on to now in terms of training and implementation of the cabinet in hospitals. And you guys actually are the engineers on this call. I'm a clinician and a physician. So I think when we talk about some of the validation of the cabinet and the studies that we've done, you may understand them much better or have a more nuanced grasp, and feel free to ask questions about that. And then my role in this project has really been around understanding what's the clinical setting to implement the cabinet. How do we do this safely? How do we put systems and workflows in place so that the staff there understand how to use this cabinet for reprocessing masks? So we'll start off with just a review of the transmission of COVID-19, as well as the methods to protect oneself in a healthcare setting. So as we know, SARS-CoV-2, or the virus that causes COVID-19, is transmitted via respiratory secretions. So the SARS-CoV-2 virus is the infectious agent. This resides in either symptomatic or asymptomatic individuals, and around 40% of those infected with SARS-CoV-2 are actually asymptomatic, which makes it very tricky to identify. And then that individual has to have a portal of exit. So the majority of the exit portal in SARS-CoV-2 is via respiratory secretions. So those can either be in droplet particles, which are larger particles that you would emit when sneezing, for example, or aerosolized particles that can be generated by some aerosol procedures in the hospital setting, or some fine particles that are released, for example, by coughing. We do know that at least some degree of transmission of SARS-CoV-2 is due to aerosolized particles. And then a third mode of transmission could be contact. So that would be contamination of a surface by one of these particles that would then be touched by another individual, and then that individual would touch a mucous membrane on their own body and transmit the virus that way. So there's multiple modes of transmission of SARS-CoV-2, and the way that it enters a new host is via mucous membranes, like on your eyes, nose, and mouth, and in your respiratory tract. And because this is a novel virus, this is a coronavirus that has not been prevalent in humans before, anyone is a susceptible host. So PPE, or personal protective equipment, we think of as really the last line of defense against disease transmission. So there's multiple system level strategies that can be employed prior to using PPE to avoid transmission. And we hear about things like social distancing and universal masking. Those are some strategies. And then we can also, do some engineering controls. So for example, when patients enter a healthcare setting, they should be triaged and cohorted into different risk categories before entering the facility. We can change the way people work, how they flow through the hospital. And then finally, when you do need to have face-to-face contact to perform patient care, then personal protective equipment is what we use to protect the healthcare workers against infection. So we choose PPE dependent on the risk of exposure. So PPE is sort of divided into different categories based on what the risk profile of the pathogen is. So for SARS-CoV-2, for COVID-19, we always need to use contact and droplet precautions while providing care. And then we sometimes need to use aerosol or airborne precautions as well, if the healthcare worker will be exposed to aerosol generating procedures or aerosols during their work encounter. We know that PPE is very effective against preventing the spread of COVID-19. So this Cochrane review was done studying various respiratory viruses and found that hand hygiene and wearing surgical masks were some of the most effective interventions at preventing transmission. And other things like wearing N95s, wearing gloves, gowns, and eye protection were also very effective. So the World Health Organization has recommended that surgical masks are worn always in areas with known or suspected transmission of SARS-CoV-2 in the hospital setting. In the community setting, we should be wearing at least cloth masks or some face covering continuously. And that N95s, which are also in other countries or other regions known as KN95s or FFP2 or FFP3 masks, should be prioritized for those healthcare workers who have to perform aerosol generating procedures. So we should use the highest level of PPE available to us, but as we know very well, and was the inspiration for this project, PPE supplies have been limited, especially this year during the pandemic. So if your supplies are limited, we have substitutions we can use. We can use the extended use strategy, which means I'm going to wear my respirator, my N95, for longer than I would typically wear it during a shift. We can employ reuse strategies. So I'm going to take my N95, clean it, decontaminate it via an appropriate method, and use it more than once. Or we can use substitution methods. So some of the substitution methods you may have seen are those, nurses wearing plastic garbage bags instead of gowns while caring for patients, or using things like bandanas or pieces of cloth in the place of masks. And that's obviously the least ideal scenario. So I'll just run through a few of the pieces of evidence around PPE and protecting yourself. So hand hygiene is one of the most important things that a healthcare worker or any individual can do to prevent transmission. And it actually had a relative risk of 3 times COVID transmission if suboptimal hand washing was employed. So this is, one of the most impactful things is just to wash your hands properly with soap and water or using an alcohol-based hand rub. We also need to choose the correct mask. So as I referred to previously, N95s or FFP2s should be utilized in higher risk scenarios, such as those where aerosols may be generated. Then surgical masks are recommended for use in a healthcare setting. And then because of supply limitations, cloth masks are meant for use in the community. We also have information to support that eye protection, such as a face shield or goggles, can also reduce transmission. And in a lot of our healthcare facilities, we're using universal eye protection now, as well as universal masking. And then gown types or gowns are recommended for use when you will be having direct patient contact, because this is part of a contact precautions. Any type of gown material essentially is acceptable. They can be reusable gowns that go through the laundry, or single-use plastic or other fabric disposable gowns. And gloves can also be employed for contact precautions. However, we should always remember, even when gloves are used, you need to perform hand hygiene before and after donning the gloves. And then another key thing to note, especially for healthcare workers that are working in a very stressful and sort of scary environment, is that more PPE doesn't always mean you're more protected. So we should use the types of PPE that are designed to protect against the pathogen in question, not just the most PPE that's available. So for example, shoe coverings, coveralls, such as those gowns that actually have the legs you put into and zip up here, and head coverings are not required for care of COVID-19 patients. And in fact, they can put the healthcare worker at more risk because you have the chance of contaminating yourself when doffing the coveralls or doffing the shoe covers that aren't really needed to protect you anyway. So that's sort of an overview of how COVID is transmitted, PPE in general, and how we protect ourselves. But now I want to focus in on N95s and get to the use of UVC for decontamination of these. So N95s are one type of mask in the spectrum of masks that you see here. They're also called filtering face piece respirators, and N95s are just one type of FFR. And these provide sort of an intermediate level of protection between those medical or surgical masks, which provide less of a seal and less protection, and those higher level masks, such as elastomeric respirators or PAPRs, these powered air purifying respirators that provide almost 100% protection against anything you might come into contact with in your environment. So some basics of N95s. What does the name mean? So the N means it's non-oil resistant. So it basically has a hydrophobic cover that resists splashing of water or droplet particles, but doesn't resist oil. And it filters 95% of particles, of which the testing is usually done at this 0.3 micron diameter. And then respirator implies how it fits to your face. So a respirator means that you should have a complete seal around your face and that no air enters in or out around the mask, such that all the air you inhale actually goes through the filter. So this schematic just shows you how an N95 is set up. So there's a melt-blown polypropylene filter that's in the middle, and that does the heavy lifting of filtering these small particles. We then have this outer layer with a splash barrier that filters a lot of the droplet particles and prevents the filter from being contaminated, some support layers, and then this soft inner layer that makes it comfortable to wear to your face. So the fit is also very important. As this describes here, the fit should be completely to the face, and users have to perform a seal check, or basically a test where they inhale and exhale every time they wear the mask to make sure there's no leakage around the mask. And then there's other types of N95s that are not appropriate for the healthcare setting. So for example, these N95s, which we see very often in California, I don't know if you ever use them in Brazil, but for example, when there's wildfires or when you're constructing something at your house and you want to protect your inhalation, we have these industrial N95s, but these do not filter what you exhale. What you exhale is just your unfiltered breath, and it only protects you. So these are not appropriate to be used in the healthcare setting. As I mentioned before, there are other types of FFRs, filtering face piece respirators. So in the US, we call them N95s. That's our NIOSH standardized name for that mask. In Europe, they call them FFP2 or FFP3s. And then in China, they call them KN95s. So essentially, they have very small differences in how they're tested and how they're certified, but their intention is to provide the same level of protection. And then when comparing N95s to surgical masks are typically a 3-layer mask with also this melt-blown polypropylene layer in the middle that has a similar filtration efficiency to the N95. But the difference is that this is not sealed to the face. So there are usually gaps here at the side of your face, gaps by your chin and by your nose that allow some unfiltered air to enter and to exit. So this is why they're better at protecting against droplets, but against the very small airborne or aerosolized particles, they can escape in and escape out. So they're not very effective for protecting against aerosol transmission. So at n95decon.com or .org, sorry, we have a number of infographics that deal with how masks are constructed and the evidence for them and some infographics. So if you have more curiosity about this, you can feel free to look at our website. But now I want to move on to decontamination. So when we're in a position where N95s are critically limited, where we do not have enough for the staff to provide care for patients, we may find ourselves in a situation where they need to be decontaminated and reused. So this is an infographic that I want to point out here is co-branded by the OSA Foundation. So congratulations and thank you for your contribution to this. But this educational infographic sort of describes some of the principles for using UVC, some of the health and safety guidelines, and then some of the design principles as well. So we will revisit this, but I just wanted to give you a quick highlight of that. So when thinking of what method we can use to decontaminate N95s, we think of 4 principles. So we have to preserve the N95 fit, we have to preserve filtration, we have to reduce bioburden, and we can't leave a hazardous residue. So to go a little bit more into detail, so the fit, as I was describing, is that tight seal to the face. So if your method deforms the mask such that it can't seal to the face anymore, that method is not an acceptable method because it destroys that seal that we need for it to be an N95. Similarly, we have to preserve the filtration. So part of the definition of an N95 respirator is that it filters 95% of those small particles. And so the filter capacity has to remain intact. Of course, we have to kill the virus or the pathogen in question to the level that it's considered decontaminated. And then we can't put a residue or something that will off-gas that's harmful to the person to inhale or that causes skin irritation or something that would be very toxic to the wearer. So this is a very well-known graphic in infection prevention literature, but it essentially shows from hardest to easiest to inactivate or kill different pathogens. And so what we're aiming for is sort of something in this range, from the high to intermediate level of decontamination. So these methods are not sterilization methods for the most part, some are, but when we talk about UVC, this is not a sterilizing procedure. It's simply meant to give the right bioburden reduction so that enough of the virus is inactivated that the virus won't pose a risk. There's some methods that are not okay to use because they either damage the filter or they don't inactivate the virus or they're dangerous. So things like washing with soap and water, submersing in alcohol or bleach, or exposing to gamma radiation will damage the filter and can't be used. Then other things like using those UVA or B boxes that they use in like salons or putting it out in the sun won't kill the virus sufficiently. And so those can't be used also. So when we come to considering UVC for decontamination, we need to make sure that we're using the right wavelength. So for this purpose, we use germicidal UVC, which falls between this around 200 to 280 nanometer wavelength range. And the absorption of DNA and RNA occurs at around 260 nanometers. This is where they absorb the most radiation and will be the most inactivated. So this is why these wavelengths are germicidal. When we come to the wavelengths of UVB and UVA, they're not sufficiently germicidal to kill the SARS-CoV-2 virus. And then when you get into the ozone generating range, ozone can be harmful for humans to inhale. And so this poses a risk to use this wavelength. We've used UVC for a long time in healthcare. We use it in hospital settings to decontaminate rooms after a patient, for example, with Clostridium difficile or typical resistant pathogens like Enterococcus or MRSA are staying in that room. We'll conduct a high-level disinfection of the room by exposing it to a UVC tower. It was also used in the Ebola virus epidemic to disinfect and decontaminate places like operating rooms to a higher level than the standard decontamination. So a key difference of this whole room or surface decontamination to the N95 decontamination is the dose. So typically the dose for surface decontamination is about 100 times less than the dose for N95 decontamination. This is very important to remember and impacts all the validation and all the testing that we have to do on things like these cabinets or the whole room systems to use them for N95 decontamination. So this is just sort of a summary of what I've reviewed. One of the key things we have to remember is the dose. We need to make sure that greater than 1 joule per centimeter squared is applied to all N95 surfaces. And we need to validate this dose with something that can accurately measure the UVC. If we can expose all surfaces of the respirator to this dose of greater than 1 joule per centimeter squared, we're likely to inactivate SARS-CoV-2 sufficiently. But still, this is an area of the literature that is relatively sparse. We don't have a ton of studies showing direct inactivation of the SARS-CoV-2 virus in secretions on N95 respirators. We also have to consider that this depends on the N95 model. So these tests are conducted mostly in the most common brands of N95s. And when you come to KN95s or different FFPs, they may not have necessarily been tested. And so we can't, with 100% confidence, assume that the same principles will apply. We also have to remember that the straps of the N95 are more difficult to decontaminate. So these require a secondary decontamination method. Typically, we're wiping them with an alcohol or a bleach solution after the decon process. And then this is not a sterilization method. It is likely to sufficiently inactivate the virus, but other pathogens that require higher level for kill or inactivation may still be there. So for this reason, it's important that the N95s be returned to the individual user. So you can't put these all in a basket and everyone just grabs a reused one. It matters that the individual who wore it the first time receives the same mask and continues to wear the same mask. Studies on performance show that the UVC irradiation is tolerated very well on these N95s, and we don't see degradation of the filter material until it reaches a dose of around 100 joules per centimeter. And some cautions to remember: UVC, as you know, is dangerous, so we can't expose eyes or skin directly to the irradiation. And then other types of UV, like those nail salon boxes or sunlight, are not sufficient to use. And then we also have to be mindful of ozone. So now we sort of have established this method of using UVC irradiation for decontaminating N95s. So how do we do it? This is where you guys will see a lot of relevance to your current work with the cabinets. So we've reviewed a lot of these factors over here on the left: the basics, the principles of decontamination, the wavelengths, and then the safety guidelines. So how do we have to design a cabinet or a system to achieve all of these? So one principle is we have to build in a mechanism to measure the dose routinely. So we want to use either a photodiode or PCI strips that are specific to this higher dose UVC and that are able to measure a joule per centimeter squared effectively. We have to make sure that both sides of the mask are irradiated. So in this cabinet design, we have 2 bulb arrays in the back of the cabinet and in the front of the cabinet. So the front and the back of the mask are irradiated at the same time. There are other systems that employ racks that rotate. And so they'll irradiate one side, rotate the rack, and then irradiate the other side. We also want to make sure that we irradiate the masks uniformly. So one of the principles that allows us to do this, and I'll show you a slide later, is that the distance between bulbs and the distance from the bulb to the mask are roughly the same. That way, the fluence level is roughly uniform when it's reaching the mask. We also have to avoid shadowing. So UVC is very easy to block, as you know. Anything like a piece of plastic or a piece of glass can block that irradiation and prevent it from reaching the surface. So we have to make sure that nothing is obstructing the way, and also the straps are held out of the way by the rack. And then we can't forget to decontaminate the straps afterwards. So they may not be fully decontaminated by UVC, and they need to be wiped by a material like alcohol or bleach. So this schematic just shows the importance of the uniform irradiation. And then an example that Tom, one of the engineers who designed this cabinet, uses that I like very much is this toaster oven. So when you put a piece of toast in your toaster oven, it doesn't usually get more dark in some areas and less dark in other areas. It's uniformly toasted. And this is using just this distance principle. So the distance between these bulbs that are emitting the heat and to the piece of toast are about the same. So then it achieves this uniform irradiation. And here is a schematic of the cabinet that I think many of you have built. This is described in our publication as the vertical chamber. So this can be built in a full height with 2 bulb arrays or a half height configuration. And by using this design, we're able to apply the correct dose of greater than 1 joule per centimeter squared in about 5 to 10 minutes per cycle. And if this were to run continuously, you can decontaminate about 5 to 10,000 masks per day. We also have a couple different designs that have been described in the publication and are more suitable to other types of clinical practice. So this horizontal chamber is also very nice and employs the same principles. It does require some metalworking capability to construct this sort of designed box. And then we also have a cylindrical chamber, which is easily built actually in a trash can. And this is more appropriate for maybe smaller facilities where they only have a couple staff members and only need to reprocess a few masks at a time. So here are a couple of publications that support the testing and validation of these chambers. So one of them by Dr. Bayer, who is our PI engineer of this whole project, as well as his colleagues, used Zmax to model the mask configuration and estimate the UVC irradiation that would be applied. And then this other publication with Martin, who is one of our collaborators from Mass General Hospital and who designed the horizontal cabinet, as well as our group and Dr. Bayer, use the different configurations of the cabinets to validate the dose applied and to demonstrate the reduction in bioburden. So this just shows the uniformity of the UVC intensity in the vertical cabinet, as well as the cylindrical design. We also found that it's important to line the cabinet with foil so that the UVC that would face the outside walls of the cabinet is actually reflected inside and increases the intensity and increases the uniformity. And then this shows some spore testing that we did. So we used Bacillus pumilis, which is a bacterial spore, but it's particularly resistant to UV irradiation. And so it's thought to be a good spore for testing of UVC methodologies. We sandwiched a spore strip in between 2 complete layers of the N95 and put it through the decontamination cycle in the cabinet. And then we found complete kill of the spores here, as evidenced by the purple. And then this is the control. If the spores are still present and alive, it will turn the culture media yellow. And then another safety consideration we brought up was the presence of ozone. So we need to make sure that ozone is not generated by the bulbs. So if you're building one of these in your own setting, you don't want to buy bulbs that are intended to produce ozone. But still, the germicidal UV bulbs do produce some ozone. And if this is contained within the cabinet, it will actually be inactivated by the UVC itself. So keeping the doors closed is actually the safest way to operate the chamber. So we have to remember that the dose of UVC is the irradiance times the time. So it's really important not to sort of get focused on the time of the cycle, because this can fluctuate based on the power of the lamps that you have. So we had to validate the dose that was applied. We have a couple ways to do this. We have these photochromic strips, which change color with various exposure to UV. And then we also have this UVC sensor module that is constructed into a photodiode. I'm afraid I would do a terrible job of explaining the intricacies of the construction of these or the measurement of UVC, but we used both methods to test the dose in the cabinet and found that it was sufficiently greater than 1 joule per centimeter squared. So here's a construction of this photodiode that Tom made in his garage. It just needs to be plugged into a 5-volt power supply. And then this is showing Tom constructing the cabinet, the first cabinet, over several days in his garage there. So some of the 3 designs that I outlined, you can see here the throughput that we estimate per day. So the horizontal and the vertical cabinet designs can reprocess 4,000 to 5,000 masks per day if they're running 24 hours a day. The smaller cylindrical model can reprocess about 1,500. And you see here, they're relatively cheap, about $1,500 for the bigger cabinets and about $750 for the cylindrical model. And you guys are part of this. We have since deployed construction efforts all over the world. So a lot of our team is located here in Boston and San Francisco. We have chapters in Mexico, in Peru, in Brazil, Ghana, Ethiopia, Kenya, and India, as well as other places that are currently constructing or implementing these cabinets. So it's been a very exciting journey. And here's some pictures. Some of these are of you guys, I bet. This is our chapter in Ethiopia constructing their first cabinet. They went for a half-height model. And then here's a bunch of you guys in Brazil having fun constructing your cabinets. So always keeping the health risks at the forefront. We have to make sure that we have safety mechanisms built into the cabinet construction, and also people operating the cabinet know about them and they're protecting their skin and eyes. We have to make sure that the lamps are not producing too much ozone and that we are protecting ourselves and the users by wiping the straps as well. So now we have gone through the validation process, we've constructed the cabinets, we feel confident in the design, but there are a lot of other things that need to be considered for implementation. So how do you take this cabinet out of the lab, out of your engineering studio, and put it into a hospital and have it employed safely? So we have, here's like just some examples of things that can go wrong if you don't think carefully about implementation. So these are the whole room commercially available decon systems. And at the beginning of the pandemic, people were putting these in a room, putting masks all around and just turning them on and thinking this will work. But you see here, there's shadowing here, masks are blocking each other. So this is rife with problems and you need to sort of think about this on the implementation side. We use an exercise in quality improvement in my previous work in Ethiopia around infection prevention to plan for implementation at a detailed level. So the team that is taking this cabinet and going to be using it in a hospital needs to think carefully about the details of operations. So how will they staff it? Will it work 24 hours a day or just one shift? How are you going to choose your staff? Are you going to choose instrument reprocessing staff, nurses, other people? Who's going to be in charge? How are they going to be trained? Questions like this need to be answered. So what is process mapping? This is a tool that we use in quality improvement, but I don't expect you to know what it is. And so here's an example to sort of explain it. So when thinking about making a cup of coffee, we start with a coffee bean on the tree, right? And then the end product is a cup of coffee. But between these two steps, you have to harvest it, you have to roast the coffee, you have to grind it, you have to boil it, and then finally you get a cup of coffee. So similarly, if we want to take dirty respirators and turn them into clean respirators, we have to follow certain steps. We have to drop off the masks, they have to be unloaded, reprocessed, repacked, returned to the user. But in reality, when we look at the process, it's more complicated because each one of those yellow blocks has many different steps. So here's a worksheet that also has some attribution to OSA here that our group has made to help facility leads plan for the implementation. So there are various sections here, starting out with the implementation at the hospital level. They have to decide that we need to do this method. They need to arrange a space in the hospital for it, write a protocol and approve it, figure out how many masks they have and sort of how much volume they need to do. And then they need to pick their team and train them. Then for a new mask to enter the system, it has to be labeled. The clinician should wear it the first time for a shift and then bring it to the drop-off area. So the clinician at the drop-off area should evaluate it, make sure it's not deformed, dirty, unusable in any way, pack it into a container that has to be breathable, label that, it should be logged in, and then brought to the decontamination area. In this reprocessing area, it has to be unloaded, then put on the rack. Someone needs to make sure that there's no shadowing of the straps or any other materials onto the respirators. When it's put into the cabinet should be totally sealed, so there's no light escaping. We should have a safety check so that the doors are locked and can't be opened while the bulbs are on. And then we also need to verify that the dose is appropriate and that we know the time it takes to achieve that dose. After this, they can be unloaded from the cabinet, and then the person touching the masks now can't be the same dirty person from before. So they need to either change their gloves or use a second staff member to unload the clean masks, do the strap decontamination, and then repack them in clean containers, put them back on the cart, and bring them to the pickup. Then at the pickup area, the user needs to identify the mask that belongs to them. They need to log it out, make sure that it's fitting all the criteria in terms of seal, do their seal check, and then wash their hands and go work. And then up here at the top and the bottom, you see the reprocessing staff. So these guys, when they come to work, they need to put on their right type of PPE and have a communication step with the people that are leaving their shift. They then do this whole process of the mass decontamination. And then when their shift ends, they need to communicate again, doff their PPE, and make sure to wash their hands and then go on their way. So this worksheet is intended for the facility, the hospital leaders, administrators, the people in charge of the process to plan for each one of these steps. There are a number of questions, about a 2-page document that we have that goes along with this, that guides them through all the details. And then here's some training topics that we recommend for the staff. So they should understand how the cabinet works, how does UVC work. They need to understand how to don and doff their own PPE safely, how to handle the masks safely so they don't cross-contaminate them or deform them, how their workflow should go, the logbook and the documentation that is recommended, and then what happens if something goes wrong with the cabinet, who do they call, how often are we going to do quality checks, etc. The hospital also needs to plan for consumables. So we need to make sure that the staff working there have enough PPE. they need to make sure that the storage containers are going to have a supply chain. So if you're using paper bags, we need to have a consistent supply of paper bags. Or if you're using a reusable plastic container, poking holes in that so it can breathe, and then having a decontamination process. And then also for the straps, there needs to be a steady supply of wipes to do the alcohol or chlorine disinfection. So we've gone through the planning process, and now finally we're ready to implement. So we have another infographic that can support the implementation of the UVC cabinet in the hospital. So this is meant as sort of a reminder to staff. You can post this in the decontamination room or hand it out to your staff of exactly what they should be doing at each step. So this goes through the steps that I just outlined of dropping off the mask, inspecting it, packing it, logging it in. Then here it gets loaded onto the rack. We put it in the cabinet. We switch the door on. We verify the dose, unloading it with a clean staff member, wiping the straps, and then packing and labeling the containers. And then at the pickup step, having the double check that this mask belongs to the right person, making sure it's only been decontaminated the appropriate number of cycles. Usually 5 cycles is the limit that some masks can handle. Some can do a little bit more, but this is very dependent on the model of mask. And then logging it out, putting it on, going back to your shift. So here's just some details on evaluating the masks. So this is a good mask for decontamination. The nose piece is still there. It has the straps. It's not obviously dirty or contaminated with blood or body fluids. There's no tears. These are not good masks. So if there's obvious soiling on the inside or the outside of the mask, if it's broken, if part of it is coming off, or if it's smushed, it can't be used. And then here's just a few pictures showing the rack configuration to avoid shadowing of the straps. So here they're very stretched out. Here's one of our cabinets in Ethiopia doing some testing of a surgical mask, and they have the straps away from the mask surface there. We have some examples of a logbook sheet. It's really up to hospital staff if they feel like they need to use this or not. This is just another check to make sure that the mask is signed in and out by the right person, and it allows for 5 cycles of decontamination. There also needs to be a tally mark on the mask every time so that it doesn't exceed the appropriate number of cycles. And then we have another reporting form that if hospitals want at sort of the larger facility level to track how much volume they're reprocessing, to log any issues or malfunctions, and to report that back to us, they can also fill out this reporting form. So that was a very quick whirlwind overview of all of the steps that we've taken in establishing the method for N95 decontamination, choosing UVC, designing the cabinet, validating it, and now thinking about implementing it in hospitals. So I'm very grateful for your time, and I will stop here and take some questions from you.
Thank you, Nicole, for your presentation. That was a great presentation. I'm sure that everyone learned a lot about N95 masks, but all of the masks, about the equipment, about UVC. Thank you for your presentation. And now we're gonna have a question section. But before, I'm just want to warn about certificate. Everyone who is watching can get a certificate via chat on Zoom. You can click on chat, and you can see a docs form, a Google Forms on chat, and just click over there, and you can put your information. And if you are watching on YouTube, you just need to go to description of the video or the commentaries, and over there you can click and just put your information. And now, let's see some questions here. Just a moment. Nicole, first question. What were your difficulties when developing your project? How is it? How is it working? What are the future perspectives?
So I think for us, one of the primary difficulties has been feeling safe and secure that every build of the cabinet is achieving the right safety considerations. So because this cabinet is not FDA approved, there's no sort of standardized regulatory approval for it, we have to be very considerate and very careful that every cabinet has to be individually tested. It has to be certified in the local environment, and we have to ensure that the right dose is being applied. For that reason, we've had to go through local level FDA approvals in various countries, and that has caused some delay, but it's also an important safety step that we take. So we're undergoing that process, I believe, in Brazil, also in Ethiopia, in Kenya, to make sure that the local or regional FDAs are certifying that.
Okay, thank you. And now, next question. What is the cost benefit ratio of your project?
That's a great question. And it's something that I think we should evaluate as some of these technologies get online. Obviously, this technology of decontamination and reuse of N95s is meant to be used only in a crisis strategy, because ideally, if you have the supply, these are only meant to be single-use devices. That being said, I know there's a lot of hospitals and clinical service areas, at least where I've worked in Ethiopia and other parts of Africa, where we almost never have the adequate supply of respiratory PPE. So in that setting, it would be very, I think, interesting and useful to understand the cost benefit ratio. But if you think about it, it must be pretty high. If these masks cost maybe 30 cents to $1, depending on the current demand, and the cabinet itself would, potentially pay for itself in one day.
Okay, thank you. Next question. Let me see here. What is recommended protection for non-healthcare workers returning to activity which interacts with the public as in university, supposing that most are still not vaccinated?
Yeah, so what PPE should you be wearing in the community?
Yeah, that's the best.
So currently, at least a face covering is recommended, at least by our own CDC, at all times in the environment. We are still in the phase of wanting to reserve surgical masks for healthcare workers, although I understand they are available at some pharmacies and they do potentially provide a higher level of protection. Something else you could consider if you're re-entering a work environment or, going about your day through the community is we know eye protection is effective. So if you have the opportunity to wear some eye protection in addition to your face mask, that can protect you at a higher level. And then also hand hygiene is very important. So you don't necessarily need to wear gloves when you go out, but you should be washing your hands with soap and water for 20 seconds as often as you can throughout the day, or at least when you sort of enter your home and you're going to be touching your face. Another really important thing to consider is that distancing measures work and separation measures work. So as much as you can, being outside and being separated from people, even if you're wearing a mask, is important to do.
Okay, thank you. Next question. The common protection for most people are clothed masks. How critical is it when no protection for the eyes are considered? It is effective, or should we all start using goggles?
So I'd say you definitely get an extra level of protection with goggles or eye protection, even glasses, because your eyes are another mucous membrane, another portal of entry rather than your nose and mouth that is pretty unrelated to the protection you're getting from the mask. So yes, you should always wear a face covering. If you add eye protection, it's better. And then the protection you get from your face covering will vary based on how many layers it has, how well it fits to your face, and what it's made out of.
Okay, thank you. That's a great question, because we are struggling with this now, because we have asked about how to use UVC in books, you know. Would UVC be adequate to discontaminate books just as N95 masks, for example, in library books?
Good question. So the first question, I think, is how well does the SARS-CoV-2 virus maintain its stability on different surfaces? So the virus can live in an active form longer on some surfaces than others. And there's multiple articles you can find on PubMed that talk about the stability of the virus. For example, on clothing, it's unlikely to last for more than 24 hours. So the risk of having, a contaminated shirt or a jacket or something is lower than like a hard metal surface. On things like aluminum surfaces or plastic surfaces, it can last for much longer, on the order of many days. If you're thinking about using the UVC cabinet for anything else, the major caution I would give you is about shadowing. So without having it really modeled and tested for an individual object, we can't be certain that the surfaces will be uniformly irradiated and exposed to the dose of UVC. So we are not recommending this cabinet be used for anything else besides masks, because you may inadvertently have a shadowed area that's not decontaminated and then introduce risk to yourself.
That's a problem, because between the pages of the books now, how can we certain that it's going to be work with books, because we have a lot of pages now?
Yeah. I think a safer strategy, for example, if you have to handle any item like a book or anything that someone else has touched, is to remember your hand hygiene. So the virus cannot be transmitted through skin. It has to be from your hands to your mucous membranes. So even if you have touched a contaminated book, wash your hands and you'll protect yourself.
Nice, great. We'll have one more question here. What is recommended log reduction? 2 log, 3 log, that should be designed for these decontamination cabinets?
So the level we need to achieve, at least for our own FDA approval, is greater than 3 log reduction. So this gives us sort of an intermediate level of decontamination. If you think of sterilization as being like a greater than 6 log reduction process, we need to do about half that, definitely -3 log or higher for SARS-CoV-2.
Okay, thank you. Now we have the last question. You say that you can process the mask 10 to 20 times. What establishes that number? Why couldn't we reuse it more?
Very good question, and I'm glad that you asked this, because I don't think I adequately covered it in the presentation. So if we think back to the principles of decontamination, so we have fit, filtration, bioburden reduction, and harmful residue. So UVC is not going to give us a harmful residue. We established that it will achieve bioburden reduction. So now we have fit and filtration. So I presented you that you need to get to about 100 joules per centimeter squared of dose to damage the filter. So that alone would allow you to decontaminate a mask maybe 10 to 100 times, at least 10 to 20 times before you get to the dose where the filter will be damaged. The remaining issue is fit, which is the most important limiting step to this process. So if you think about your typical, the blue N95, the 3M model that you see most people wearing, even in donning and doffing it, without doing anything else, if you put on the mask and you take it off 5 times, it's very unlikely to seal to your face properly after that. So for those masks, just by using them, not by the decontamination process, we're limited to about 5 cycles. And that's with the caveat that you have to do the seal check. So every time the healthcare worker puts it on, they need to check that it fits. If it doesn't fit, they can't use it. There are other masks, like some of the duckbill masks, that seem to fit a little bit longer than 5 times. So maybe those can be used 7 times, 10 times, but it's really not very well tested. And if the fit fails, it doesn't matter if it's perfectly clean. You still can't use it because it won't protect you.
Okay, thank you. That's it.
Sorry, can I ask you one more question now?
Yes.
Because in some case, the UV lamps are together, almost touching, centrally. In another cases, they are separate by the entire chamber. Is there any difference in terms of efficiency or not?
So I think the key issue in the spacing of the in the spacing of the bulbs, and if I can't answer this properly, we can connect you to Tom or Anderson, some of the engineers who helped design this, is that they're spaced in order to provide uniform irradiation. So of course you want the intensity to be enough that the correct dose is exposed to the surface of the mask. But if you move the mask closer to get a higher intensity, you'll also be changing the uniformity. So both principles have to be followed for the mask to be uniformly and at the right dose decontaminated. I don't know if that answers your question.
Yeah, understand. Thank you.
About N95 masks. And thank you, Nicole Starr, for having this time with us. And that was an amazing time. We learned a lot, and that was so important for us and for everyone watching. I'm sure of that. And that's it. We're going to end now the transmission, the broadcast. And thank you, Nicole.
Thank you very much.
What?
Thank you. Bye-bye.
Thank you.
Thank you.
Gabriele, you've closed the YouTube live.
Have you closed?